Pathologist Professor Louise Jones is part of the North Thames NHS Genomic Medicine Centre. She explains how they've adopted fresh sampling without compromising on diagnosis. She shows us some of the techniques she uses for whole genome sequencing samples, and she gives us some of her top tips.
We collect tissue fresh from theatres and aim to basically cut all of our specimens fresh. And we do everything that we would normally do when the tissue is fixed. We just do it before it's fixed. We get the specimen, we weigh it, we orientate it according to the surgical details, and then we paint the different margins just as we would routinely. We always stipulate, as I'm sure everyone does, stipulate each time which margin you've painted which particular colour, so it can always be reorientated. It happens that we do red superior, inferior is either green or yellow, lateral is either yellow or green. Medial is blue, and then we do anterior and posterior black. Before we slice into the specimen, we try to fix the paint a little bit onto the surface. And you can do that just by dabbing with a tissue. We also tend to spray with 70% ethanol, which we find quite effective. And that just helps prevent the ink smear into the cut edge of the specimen. We usually slice into the specimen just as we would normally when it was fixed, but doing it when it's fresh. And that works really well when you can palpate or visualize a tumour, and then we can take a piece directly under visualization. There are things that we have to be careful of, so we're very mindful of margins, but if you can see the tumour, you know whether it's close to a margin, and then you'd need to avoid that area. And of course we have to be sure that we leave sufficient tumour in the specimen so that we've got enough for an accurate and complete diagnosis. So then we slice in as we would normally and hopefully detect the tumour. Sometimes even when the predicted size of the tumour would suggest it's going to be sufficient to take a piece of tumour under direct visualization, just the configuration, the pattern of growth of the tumour can mean that actually you can't see it. Of course, that's hugely disappointing, but at the end of the day, it's your clinical judgment as to whether or not you feel you can take a piece of tumour, and sometimes it's just not possible. Quite a lot of our specimens come with a localising wire, and they can be difficult because obviously we can't cut through the wire, so we need to find the plane in which the wire is inserted and really cut along it. It's a challenge that is there whether the specimen is fresh or whether it's fixed, and really it's about moving along the plane of the wire as you go into the specimen, and usually that helps avoid sort of cutting across it and allowing you to cut along it. And that's useful too, because then you tend to bisect the specimen at the site where the wire is localising the lesion, so you have a better chance of identifying that lesion. We've been working together with other pathologists around the country looking at different approaches to try and facilitate taking samples from small tumours. And in particular, actually in breast, we get a lot of small tumours with the screening programme. So this is really useful. One of those processes is to take a biopsy using the same sort of biopsy needles that are used by the radiologists in clinic. You can orientate and paint the specimen as you normally would, but instead of then slicing into it, you can actually pierce it with the biopsy needle and pull out a small, fine core biopsy. There is sufficient DNA from a large percentage of those core needle biopsies, so this is a really good way of sampling small tumours, and it causes very little distortion of the tumour, if any at all. It can be difficult to even see where you've done the biopsy.
If a pathologist isn't available to take fresh tissue, A surgeon can take a fresh post-operative core biopsy sample and store it fresh. The remaining sample can then be fixed in formalin. Alternatively, a pathologist may want to use this technique themselves to avoid disrupting the sample.
One of the things that I usually do if the tumour is of sufficient size is actually to bisect the tumour in my slices and then take a piece sort of a bit bigger than core size really from one half of that slice, which I would then freeze, and then take a piece from the mirror image of that, which we then fix. And so we're able to look at the area that we have sampled and we can assess it for cellularity and so forth. In some of our labs we have a ready supply of liquid nitrogen, so it's very easy just to put the sample onto a tinfoil boat and float it into liquid nitrogen. It's very quick, really freezes the sample rapidly. But some of our hospitals don't have access to liquid nitrogen, and what we can do in those situations is freeze the tissue using something called cryospray. And cryospray is something that's used in pathology laboratories widely. It's used for diagnostic frozen sections, so we know that it freezes the tissue sufficiently to be able to preserve it, and it's very simple to use, and you can either spray the tissue directly or you can cover it with foil and spray the foil. It takes a little bit longer, but only a matter of 30 seconds or so. And some people prefer that because you get less chance of aerosol from the tissue. And then just take that frozen sample and put it into an Eppendorf, which then usually we put onto dry ice or indeed keep it in liquid nitrogen. Another technique is to use a punch biopsy, and that's done under direct visualization. You cut into the specimen, take a slice, and then literally just use the punch to do a core out of the slice. Again, it causes minimum disruption. It's nice because you can avoid margins and make sure that you're taking from a part of the tumour that won't compromise your assessment later. And of course you also know exactly where you've taken the biopsy from because you can see the core on the fixed sample later on when you're diagnosing it. And then that tissue can get frozen either using liquid nitrogen or cryospray, whichever's available. We know from work that we've done on these samples that either way the nucleic acid is completely intact and the whole genome sequencing that you get is perfect. So it's really down to personal preference which you use.